ask a responsive child, "Are you choking?" If the child is coughing, wheezing, or can speak, encourage the child to cough until she expels the object. If the child cannot speak or breathe, give the emergency responder statement and alert emergency medical services.
Are you choking? My name is Joss and I'm an emergency responder. May I help you?
After the child indicates she wants your help, a nod will do. You may use back blows, abdominal thrusts, or chest thrusts to attempt to dislodge the object. Techniques for handling a conscious choking child vary internationally. Your emergency first response instructor will teach you the techniques appropriate for your area. And it's those you should use when assisting a choking child. In general, however, there is no clear evidence that one technique is better than another, but there is evidence that if one technique does not help a choking child, another one might. To deliver back blows, take a position to the side and slightly behind the child. Supporting the chest with one hand, lean the child forward, like this. A small child may be placed across your lap, like this. Next, while supporting the child, deliver 5 sharp back blows between the child's shoulder blades using the heel of your hand. Continue the 5 back blows until the object is expelled or the child becomes unconscious. The aim is to relieve the obstruction with each back blow rather than to give all 5 back blows. After delivering the back blows, look in the child's mouth and carefully remove any visible objects. Abdominal thrusts use residual air in the child's lungs to blow the obstruction clear. To begin, stand, sit, or kneel behind the child with your arms around her waist. Find the child's navel with one hand. Make the other into a fist and place the thumb side against the child's abdomen slightly above her navel, like this. Put your other hand on top of your fist. Bowing your arms so you don't squeeze the child's ribs, pull your hands inward and upward in a thrusting motion. Continue the 5 abdominal thrusts until the object is expelled or the child becomes unconscious. The aim is to relieve the obstruction with each abdominal thrust rather than to give all 5 thrusts. Another technique used to assist a conscious choking child is chest thrusts. In some regions, chest thrusts may also be used on children who are markedly obese instead of abdominal thrusts. To begin to deliver chest thrusts, stand, sit, or kneel behind the child and place your arms around the body, under the armpits. Place your chest against the child's back. Locate the chest compression site. This is the same compression site as CPR, over the lower third to half of the sternum. Next, make a fist and place the thumb side on the thrust site. Place the other hand over the outside of the fist. Perform up to 5 quick inward thrusts. These thrusts are similar to CPR compressions but sharper and delivered at a slower rate. Avoid putting pressure on the rib cage with your arms. Continue the 5 thrusts until the object is expelled or the child becomes unconscious. The aim is to relieve the obstruction with each chest thrust rather than to give all 5 thrusts. Continue using one or more of these techniques until the obstruction is relieved or the child becomes unconscious. If a responsive choking child becomes unconscious while you're trying to help, carefully help the unconscious child to the ground. Next, if you have not already done so, activate emergency medical services and immediately begin CPR, chest compressions. The compressions may dislodge any obstruction. After giving chest compressions, you should quickly look inside the child's mouth to see if there is any solid material visible in the airway. If an object is seen, you should remove the object with your finger. If no object is seen or the object has been removed, you should proceed with 2 rescue breaths. Finally, continue to give 30 compressions followed by attempting 2 rescue breaths, just as you've already learned. Continue CPR until the obstruction is relieved and the child becomes responsive or emergency medical services arrives. When you practice these techniques in class, be sure to simulate thrusting. Never perform thrusts on a child who does not have an obstructed airway. With choking infants, begin with a scene assessment. Stop, think, and act. If appropriate, consider giving your responder statement to the parent or guardian, asking their permission to assist the infant.
I'm an emergency responder. May I help you?
If the infant is coughing, wheezing, or crying, allow the infant to keep trying to expel the material on their own. However, if the infant is obviously choking but cannot cough, wheeze, or cry, they need immediate assistance. Begin by looking in the infant's mouth and carefully remove any visible objects. Should no visible objects be seen in the infant's mouth, use back blows to help the infant expel the object. First, position the infant face down on your forearm and support the infant's head and neck with your hand, like this. With the infant's head slightly lower than the body, deliver up to 5 distinct and separate back blows between shoulder blades with the heel of your hand, like this. The aim is to relieve the obstruction with each blow rather than to deliver all 5 back blows. If the object is not dislodged after 5 back blows, support the infant's head and turn the infant over. Keep the infant's spine straight while turning him over. Look in the infant's mouth and carefully remove any visible objects. You may consider administering chest thrusts if back blows are not effective. To perform chest thrusts on an infant, you may rest the infant on your arm or thigh by positioning his head lower than the body, like this. Next, locate the chest compression site. This is the same compression site as infant CPR. Provide up to 5 distinct chest thrusts. These are sharper in nature to CPR chest compressions and delivered at a slower rate. The aim is to relieve the obstruction with each compression rather than to deliver all 5 chest thrusts. Keep the force of compressions straight down. Avoid pushing on the rib cage or the lower tip of the breastbone. You may want to leave the other hand in position on the infant's forehead. After the chest thrusts, or if the infant begins to cry, look in the infant's mouth and carefully remove any visible objects. If the object is not dislodged, repeat back blows and chest thrusts. Continue until the object is dislodged and the infant begins to breathe, cry, or cough, or the infant becomes unconscious. If a responsive, choking infant becomes unconscious while you are trying to help, your forearm can also be used to support the infant. Next, yell out for help and assistance and begin CPR.
This baby is unresponsive and not breathing properly. Call for help.
Following each set of chest compressions, quickly look in the child's mouth and attempt to remove any visible obstruction. If an object is seen, you should carefully remove the object. If no object is seen or the object has been removed, proceed with 2 rescue breaths. Continue CPR, 30 chest compressions followed by 2 rescue breaths. After 5 sets of CPR, call EMS. Continue CPR until the obstruction is relieved or EMS arrives. During practice, remember that you never perform abdominal thrusts or chest compressions on an infant who does not need them. When trauma occurs, a complete injury assessment allows you to attend to and report both external and internal injuries that may affect a child's condition. Remember that you always begin with the cycle of care, checking to see if the child is responsive and breathing normally. As you approach the injured child, assess the scene. Stop, think, and then act. Use barriers as appropriate, check for responsiveness, and give your responder statement when needed. Call EMS and make sure you obtain consent from parents or guardians if necessary. Since you only perform an injury assessment on conscious, responsive children, make sure that you constantly explain to the child what it is that you're doing. Speak calmly and handle a frightened child very gently. First, stabilize the child's head and neck, instructing her to answer verbally without nodding or moving the head. Stop the assessment immediately if the child complains of head, neck, or back pain. In this case, continue to stabilize the spine and wait for EMS. Start your assessment at the head and work toward the child's toes. Feel for deformities on the child's face, gently running your fingers over the forehead, cheeks, and chin. Next, check the ears and nose for blood or other fluid. Again, if you suspect a head or neck injury, stop your assessment and wait for EMS. Check to see if the child's pupils are the same size and have her follow your finger with her eyes without moving her head or neck. The eyes should move smoothly together. Feel the skull and neck for abnormalities. If the child complains or you find something, stop the assessment. If you can reach the shoulder blades, slide or place one hand over each shoulder blade and gently push inwards. Then move your hands outward to the shoulders and press gently inward with the palm. Next, run your fingers over the collarbones like this. You're looking for irregularities, blood, moisture, pain, or other unusual sensations. Place one hand on the shoulder to stabilize the arm and gently slide the other hand down the upper arm, elbow, and wrist. Repeat on the other arm and ask the child to wiggle her fingers and squeeze your hand. Note any weaknesses or differences in strength. Inspect the child's chest for deformity by placing the palm of each hand on one side of the child's rib cage. Press in gently. Next, gently put your hands under the child to check the spinal column. Cover as much area as possible without moving her. If you find any irregularities or pain in the spine, stop the assessment. Use one hand to gently push on the left and right of the child's abdomen, both above and below the navel. Next, move your hands gently over the hip bones to check for swelling or hardness, tissue softness, unusual masses, joint tenderness, and deformities. Avoid pushing inward on the hips. Move down the lower body, and starting with the thigh, slide your hand down the upper leg, knee, lower leg, and ankle just like you did with the arm. Make sure you ask the child to wriggle her toes and press the sole of her foot against your hand. Repeat this with her other leg. After your assessment, note areas of pain or abnormality and attend to any injury you can. Be prepared to report your findings to EMS personnel once they arrive. Continue to monitor the child using the cycle of care. Bandaging helps control bleeding, immobilize injuries, and reduce contaminants entering wounds. It's a skill that can make a child more comfortable or save her life, depending on the circumstances. Remember that you always begin with the cycle of care, checking to see if the child is responsive and breathing normally. As you approach the injured child, assess the scene. Stop, think, and then act. Use barriers as appropriate. Check for responsiveness and give your responder statement when needed. Call EMS and make sure you obtain consent from parents or guardians if necessary. If during your injury assessment you find an injury needing bandaging, use this skill, especially if emergency medical service is either delayed or unavailable. First, locate or secure a first aid kit. Most kits have several types of bandages. Choose the best bandage based on the injury or make the best use of whatever is available. Apply roller bandages directly over a sterile dressing covering a wound. Remember, as a general rule, once you have a dressing in place, don't remove it. To apply the roller bandage, start below the wound and work upwards towards the heart. Wrap the bandage firmly and consistently, but don't make it too loose or too tight. Make sure you leave fingers or toes exposed so you can check circulation. Secure the end of the bandage by tucking, tying, or taping it in place. When bandaging a foot, secure the bandage by wrapping it around the ankle several times. Then, back over the injury site on the foot. Start a hand bandage in a similar fashion, working around the thumb and wrist. For elbow and knee injuries, wrap above and below the joint to stabilize the injury. Use a triangle bandage to support arm, rib, or shoulder injuries. First, place the long edge of the triangle over the shoulder on the uninjured side. Then bend the arm at the elbow and bring the forearm over the chest and bandage. Next, bring the lower end of the bandage over the shoulder on the injured side and tie it off in the back of the neck. Make sure you support the hand, but leave the fingers showing so you can check circulation. If you suspect broken ribs or you want to secure the arm firmly, use a second triangular bandage to hold the arm against the chest. Tie the bandage over the sling and around the chest. Illness assessment helps you find and report medical problems that affect a child's health and may assist treatment. You can use this skill to determine if EMS is necessary or to find out what first aid you can use to assist the child. You'll assess the child by asking questions and by checking the child's respirations, pulse rate, temperature, skin moisture, and color. As you've learned, you start your primary assessment. After giving the responder statement, assuring the child's lifeline, and obtaining parent or guardian consent, get something to write on so you can record what you find. An illness assessment sheet may be found in your participant manual. Infants and some children cannot answer the questions in the illness assessment. In these situations, parents and guardians may be the only sources of information. To help you to remember how to begin an illness assessment, use the mnemonic SAMPLE. SAMPLE stands for signs and symptoms, allergies, medications, pre-existing medical history, last meal, and events. The S stands for signs and symptoms. Signs are something you see is wrong with the child. Symptoms are things the child tells you is wrong. Ask how the child is feeling and what occurred immediately before they felt bad. Ask questions like, how do you feel now? When did you start to feel bad? What were you doing when you began to feel bad? And where were you when you began to feel bad? When looking for signs, check the child's pulse, respiration rate, and temperature. To find a child's pulse, use the radial artery. Find the artery on the wrist next to the thumb side of the hand. Slide 2 or 3 fingers into the groove on the wrist, immediately below the hand on the thumb side, and count the number of beats in 30 seconds. Then multiply this by 2 to get the pulse. The average pulse for a child is from 70 to 150 beats per minute. Determine if you would characterize the pulse as strong, rapid, or weak. To find an infant's pulse, use the brachial artery. Put your index and middle finger between the infant's elbow and shoulder on the inner side of the arm and gently push in. Count the number of beats in 30 seconds and multiply by 2. The average infant pulse ranges from 100 to 160 beats per minute. Again, determine if the pulse is strong, rapid, or weak. If you can't find a child's pulse, just move on with your assessment. Next, check the child's breathing. First, look for signs and symptoms of respiratory distress, such as strange noises, and the child complaining about pain, shortness of breath, or dizziness. When possible, simply watch a child's chest rise and fall and count respirations. If you cannot see the child's chest rise and fall, you will need to place a hand on the chest. Children often alter their breathing rate if they become aware their breaths are being counted. Therefore, use the technique shown here to mask your efforts and to obtain an accurate respiration count. Position the child's arm so that your hand rests on the child's abdomen. Count the child's respirations for 30 seconds and multiply by 2 to determine the respiratory rate. Average breathing rate for children is 18 to 40 breaths per minute, while infants breathe 30 to 60 breaths per minute. Determine whether respirations may be described as fast, slow, labored, wheezing, or gasping. Next, check temperature and moisture by feeling the child's forehead with the back of your hand. Characterize it as warm, hot, cool, moist, or clammy. You'll also want to check the child's color. Is it pale, gray, reddish, bluish, or yellowish? Does it have blotches? If the child has dark skin, you can check for color change in the nail beds, lips, gums, tongue, palms. Whites of their eyes, and earlobes. The next part of the mnemonic sample is A, which stands for allergies. Ask the child or parent guardian if the child is allergic to anything, food, drugs, airborne matter, etc. Has the child ingested or taken anything they may be allergic to? Has the child been bitten or stung by an organism? If a severe allergic reaction occurs, treat as a medical emergency and follow primary care procedures. In severe allergic reaction, anaphylaxis can be treated by epinephrine, also known as adrenaline. Children who have suffered a prior episode of anaphylaxis often have prescribed for them an auto-injector of epinephrine. Have the child use the auto-injector or assist them with its use. In unusual circumstances, when advanced medical assistance is not available, a second dose of epinephrine or adrenaline may be given if symptoms of anaphylaxis persist. Children who use an auto-injector should see a doctor. Next, the M in sample stands for medications. Ask the child if he takes medication for a medical condition. Try questions such as, "Do you take medicine?" or "Did you take any medicine today?" How much? When? If possible, get the child's medication so you can turn it over to EMS. The P in sample stands for pre-existing medical history. Ask the child if he has any medical conditions like heart conditions, diabetes, or asthma. The L in sample stands for last meal. Ask the child when he last had a meal and what he ate. The last letter in sample is E, which stands for events. Ask the child or note the events leading up to the illness or injury. Now that you've practiced the 12 emergency first response care for children skills, let's apply them to some realistic situations. Watch as the emergency responder in each scenario adapts to the situation. In this first scenario, the emergency responder witnesses an accident. The emergency responder begins by checking the child's responsiveness.
Are you okay? This is Edgar. I'm an emergency responder. May I help you? Diego, are you okay?
If a bystander is available, have that individual go call for help.
Go for help.
Next, he turns the child and begins a primary assessment using the cycle of care to guide him. First, he checks for an open airway and normal breathing. This responder finds the child is unresponsive and not breathing normally, so he begins CPR, moving through the cycle of care by beginning chest compressions and then rescue breaths. The emergency responder continues with care until EMS arrives.
6, 7, 8, 9, 10, 11.
Hi, Tanner. Hi, Tanner. You ever count your hand? Yeah.
A guardian suddenly discovers a baby isn't breathing.
Tanner? 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 1, 2, 3, 4, 5.
After 1 to 2 minutes of care, the mother alerts EMS of the problem.
Hi, my baby's not breathing and is unresponsive. 28.
She provides the EMS dispatcher with all the important information, answering their questions directly. By alerting EMS, an anxious mother gets advanced care on the way.
4, 5, 6.
As an emergency responder who knows how to handle situations involving injured or ill children, you can make a difference and offer the assistance that may improve a child's chance to survive and recover. Hopefully, you won't ever have to use your skills. But if you ever do, you know that you have the ability to help a child in need.